Thanks to you, Dr. Khalid, and thanks to Dr. Ahmed Nasser for the invitation. It's a privilege to be here. So, 𝗔𝗹𝗶 covered the endovascular reconstruction of the aortic bifurcation. It's been talked about a lot of time nowadays. It's evolving technique, and lots of centers have been using it. So just looking a little bit on the background, so peripheral vascular disease affects millions of people around the world, and the symptoms vary from intermittent claudication to chronic limb-threatening ischemia. However, the aortic bifurcation is very prone to atherosclerosis, and disease of this area can cause plenty of symptoms ranging from intermittent claudication to critical limb ischemia. However, the guidelines for managing 𝗤𝐶 and 𝗤𝐶D patients recommend open surgery. And usually endovascular surgery or endovascular intervention is reserved for only high-risk patients that can't be considered for open repair. And there are reasons for that. So the outcome of open surgery is usually good. With long-term patency can achieve 90%. However, there is a catch here that the mortality rate or the early mortality following open repair can reach 4 or 5%. And the morbidity is much higher and can achieve 10%. But even more than that, it's about the recovery of the patient. And I usually tell my patient that you will feel that you have been hit by a bus. And you can't go back to your baseline for at least 3 to 6 months before you can go back to your usual activities. And this is because the majority of these patients have significant comorbidities. The majority of them are diabetics, they have ischemic heart disease, chronic kidney disease. So it's not only single disease, it's just multi-systematic disease. And usually these patients before the endovascular advancement who are not fit for open surgery, they get offered extra anatomical bypass, namely 𝗔𝗔𝗋𝗋𝗋, 𝗟पछि𝗰𝗶𝗄𝗆, or 𝗪-𝗪 crossover. And the outcome of these extra anatomical revascularization is not as good as open surgery, with high risk of infection, high risk of reocclusion. Then there was the need to change, and the European Society of Vascular Surgery guidelines in 2017 recommended endovascular first for 𝗤𝐶 and 𝗤𝐶D patients. However, they put two important conditions for that. One is the intervention has to be performed by a very experienced team. And the second condition, which again is very important, is the intervention should not compromise any future surgical intervention. The kissing stents have been used, and they have been used for a long time. And they have been used to revascularize the aortoiliac occlusive disease. However, there was always inferior outcome when compared to open surgery. And there has been lots of studies, lots of investigation in order to reach the optimal solution to get the best outcome. And covered versus balloon expandable stent trial showed that there is significance in using covered stents in relation to the outcome over the balloon expandable stents, especially in 𝗤𝐶 and 𝗤𝐶D. However, the results were still inferior to open surgery. And again, there have been lots of investigations and lots of studies in order to look why kissing stents don't have the same outcome. So several studies looked into the flow disturbance and whether this can affect the outcome. And several studies found that the disturbed flow causes disturbance of flow and recirculation, mainly due to radial mismatch, which is defined that this is the difference between the diameter of the stent and the diameter of the aorta. And the dead space that happens outside the stent and causes the recirculation. And this disturbed flow and recirculation can trigger the onset of progression of atherosclerosis, thrombus formation, and intimal hyperplasia. This is worse and more significant when the stents extend for more than 2 centimeters in the distal aorta. Hence was the objective of the 𝗔𝗹𝗶, or the covered endovascular revascularization of aortic bifurcation. And the main objective was to reduce the mismatch in order to optimize the blood flow. And the concept of the 𝗔𝗹𝗶 involves at least one aortic stent and 2 iliac stents that extend into this aortic stent and go down to the common iliac and even to the external iliac if needs be. And the available balloon-mounted stents, or the balloon expandable covered stents that can be used as aortic stents, are there. So there is the Atrium V12, there is the Bard Livestream, there's the Bentley aortic graft, and there is the Viaband VBX. And all of them have different lengths, which can tailor the need to use different length in the aorta. However, in order to reach whether the 𝗔𝗹𝗶 concept is best and cause better outcome than the already used and have been used for years, namely the kissing stents, so the group in the Netherlands measured the hemodynamics and the flow disturbance in the 3 models: bare metal kissing stents, covered kissing stents, and the 𝗔𝗹𝗶. And they looked into the mismatch, and they looked at the wall shear stress and the recirculation. And they concluded that the mismatch is the least in the 𝗔𝗹𝗶, and it is the most physiological reconstruction out of the 3 models. However, if the iliac artery or the disease is confined to the iliac artery, kissing stents can be used then. Then there is the concept of the AFX graft, which was designed mainly for aortic aneurysm. It's a unibody endograft that can sit on the aortic bifurcation. The benefit of it is it reconstructs the aorta and reduces the radial mismatch because it can be overstretched to the dilated aorta, and at the same time it preserves the bifurcation and the need for future up and over cross to treat any of the limbs. However, it comes with a catch because the large profile makes it slightly more difficult. The other thing is the difficulty in position of the unibody in an occluded iliac arteries or tightly stenosed iliac arteries. So in order to again measure the superiority of the 𝗔𝗹𝗶 in the 3 stents configuration versus the unibody endograft of the FX, again the group from the Netherlands looked into in vitro about the mismatch and the circulation and the flow pattern. And again they found that the flow pattern and the hemodynamics are better with the 𝗔𝗹𝗶, the 3 stents configuration. And the hemodynamics is more desirable in the 𝗔𝗹𝗶, which should reduce the thrombosis and have better outcome. In his latest update, Michel Reenen from the same group in the Netherlands looked at the outcome of 𝗔𝗹𝗶 over 130 patients, kissing stents for more than 600 patients, and AFX 90 patients, all used for aorto-iliac occlusive disease. The good thing or the important point to look here is that the majority of patients who had 𝗔𝗹𝗶 had previous intervention. And again, the majority of patients, or 1/3 of the patients, were for CLI. And almost like 95% were task C and task D, so incomparable with other groups. Looking at the outcome, the AFX has slightly superior outcome than the 𝗔𝗹𝗶, but both of them are much better than the kissing stents. And again, the St. Thomas's group from London looked at more than 9,000 patients, and they compared the outcome in patients who had 𝗔𝗹𝗶 versus open surgery and versus kissing stents. And they found that got 10 minutes.
One more minute.
So very quickly, they found again that the best outcome for the CRAP, especially at the early outcome. And again, the same group at St. Thomas's looked at the outcome of CRAP in the UK in more than 116 patients. And the majority of them were for either aortic or iliac occlusive disease. And again, they concluded that it is a very viable option for iliac occlusive disease, mainly for 𝗏𝑐 and 𝗏𝑐. And then there is the question of medical management of these patients and optimization with statins and dual antiplatelets, and some even suggest anticoagulation. I think it's very difficult to go through these, but these are the examples of the cases that can happen. So even for unilateral iliac occlusion, and again for total aortoiliac occlusion with balloons in the renal arteries. Thank you.